Alhamdulillah wa salatu rasulillah. Assalamu alaikum wa rahmatullah. This is Dr. Amber Khan. I'm the chair of IMANA Education. We're back with another webinar tonight. And this week is National Health Education Week. And in light of that, IMANA Education Committee would like to take this week and tonight as an opportunity to help and to educate the IMANA community better in understanding a very important but rarely discussed medical issue, and that is male pelvic pain. There are men who suffer in silence due to their personal discomfort of broaching this topic with their physicians. And our hope with this webinar is to break stigmas and to provide information for those who need help. We are very proud to have Dr. Tayyaba Ahmed back again for this webinar. Dr. Tayyaba Ahmed, she is a doctor of physical medicine and rehabilitation. She was born and raised in New York, and she completed her BS and DO program at the New York Institute of Technology. She trained at the New York College of Osteopathic Medicine, at Northwell Health Plainview Hospital, and at NYU Langone Medical Center. Dr. Ahmed is a board-certified physical medicine and rehabilitation physician, and she's also a fellow of the Academy of Physical Medicine and Rehabilitation and a member of the International Pelvic Pain Society. Dr. Ahmed is a contributing author to a textbook, which is considered a staple during every physiatrist training. And so we're very happy to have Dr. Ahmed back again today to discuss understanding male pelvic pain. And whenever you're ready, Dr. Ahmed, we'd love for you to start. And thank you again for sharing your expertise with IMANA.
Thank you so much for having me back. And although this is a male topic, there are many women who have men in their life who may benefit from this. So I hope that this is helpful for men with pelvic pain, men and women who are treating patients with pelvic pain, and anyone who's just curious to learn about it. So I'll try to be as layman's as possible, talk in layman's terms. So, this is good for the community. And if you haven't checked out the talk that I did about a year ago for the females with pelvic pain, but I really wanted to do something very different this time, so we're going to do the men. All right, inshallah, let's start. So chronic pelvic pain. Chronic pelvic pain is widely misunderstood, and that's because of many reasons. There are a lot of organ systems that are in the pelvis. So there is the prostate, there's the bladder, and there's the bowel. Because there are so many organs in the pelvis, the symptoms tend to overlap, and patients may spend a lot of time investigating the symptoms and not understanding the cause. It is a persistent non-cyclical pain that's been going on for over 6 months by definition. It affects up to 16% of men worldwide. And like I said, it's difficult to treat. So we're working with GI doctors, gastroenterologists, urologists, orthopedic surgeons, neurologists, pain management, colorectal surgeons, and rheumatologists. This is a little difficult to understand over here, but you can see that there is a huge overlap in men particularly, as well as females, but sexual dysfunction, pelvic pain, and pelvic floor dysfunction. Men with chronic pain have greater rates of depression compared with controls. So, and a lot of times that could be due to poor sexual function or dysfunction. It tends to have a negative impact on individuals with ejaculatory pain, and mental and physical and quality of life is decreased. So for a lot of males, their sexual function plays a huge role in their quality of life. And so if there is any pelvic pain, it tends to cause an overlap. And understanding pelvic floor dysfunction and how it overlaps is what we'll basically be going into. Here you can see acute bacterial prostatitis, acute UTIs, testicular variceles, pelvic congestion, and then tumor malignancies. A lot of this stuff is stuff that I'll go into more detail, but they're usually typically ruled out by their urologist. And then Here you see this little overlap. There's a chronic prostatitis, the chronic pelvic pain syndrome, and then here is the erectile dysfunction. So you can see that the overlap is there. So you could have pelvic pain and also have erectile dysfunction or premature ejaculation or a delayed ejaculation and diminished penile sensation. So just because someone isn't necessarily complaining of pain doesn't mean that they don't have a sexual dysfunction. They could be here. And then pain in the lower abdomen, the groin, the penis, the testicles, the perineum, without the sexual dysfunction, which I'll see as well. Many men who don't have any issues with erection or ejaculation, and those are this small little population. So what is chronic pain? Chronic pain is, what we said was over 6 months. Usually there is mechanical change in this scenario. It could be intercourse, it could be masturbation, it could be something that has happened that may now cause some sort of mechanical change. It could be a labral tear, it could be a fall on the tailbone. There's a ton of things that it could be: interstitial cystitis or acute or an acute UTI or prostatitis. Whatever it is, usually it causes a muscle spasm, which then leads to a decrease in circulation. So when muscles are tense and they're tight, they're not able to have that circulation that is typically seen or needed. Arteries and veins and nerves travel together. The arteries and veins are not oxygenating, and the muscles are now weak. They're tight, they're spastic, and they're short, and causing that peripheral nerve irritation. So the nerves coming from the spinal cord into the pelvis. And then the problem is that it causes a central sensitization in the brain and the central nervous system. And now the body doesn't know how to respond because it feels like this is the new normal. This often has increased inflammation and compensatory changes. So you can now have some constipation because you're having some tight pelvic floor muscles, or you can have some hip pain leading to some pelvic floor issues. So there is a lot of compensation within the pelvis, and you can really go in and out of this cycle in any of these places, which is what this was meant to describe. So what is the pelvic floor? The pelvic floor is it's a set of muscles that act like a hammock between the pubic symphysis and the tailbone. The bladder, the prostate, and the descending colon run through the pelvic floor. Most people don't know this pelvic floor exists. When it does, it exists. It's normal. It should be, strong, not necessarily tight, not overactive, or not necessarily loose or underactive. It should, a lot of people will hear the term Kegels, maybe not so much in men as in women. And a lot of people tend to overact, so that not understand what you're supposed to do when. So muscles can be overactive, and when they're overactive, these are the muscles that typically cause pain. When they're underactive, they are usually when you have weakness and because of the weakness, there is some incontinence. That's a very generalized term. There could be a little bit of overlap between some of the muscles in the front and some of the muscles in the back. So when people have a prostatectomy, there is always a fear that there's going to be a prolapse of the bladder coming down, and then the patient's going to have urinary incontinence, and because the pelvic floor may not be able to hold it. So a lot of doctors will say, okay, do some Kegels and strengthen it. Now, to understand, doing some Kegels could be fine. However, if you do too many, in some scenarios, I've seen patients come in and say, I did 300 Kegels in a day, and now for 6 months straight, and now their muscles are overactive. And now they're presenting with penile pain or perineal pain or numbness or tingling. So understanding that there is a balance between overactive and underactive muscles. As I also said, the muscles are allowing for urination, ejaculation, erection, and bowel movement. So for men, these muscles are key. If they're too tight, they can inhibit all of those functions. This is the pelvic floor, looking at it from obviously below. Basically, the pelvic floor is very similar in females, except in males, the genitals. So there's the bulbospongiosus muscles over here, and then there's the ischiocavernosus muscles on the sides. So there's one on each side, and this is the perineum. Perineal body is over here, but typically the region between the scrotum and the anus is the perineum. Just to understand, there is a puborectal. So the pubic bone is over here. So between the pubic and the rectum is the puborectalis muscle and the iliococcygeus, and then the pubococcygeus, all the way down to the coccyx, which is down over here. Understanding that those three muscles are the major pelvic floor muscles, you don't have to have it memorized, but when people say pelvic floor, they're typically talking about all of these muscles here that you don't even know you have. So what has likely been done, usually by the time a patient comes to see me, they've already seen a urologist. Men typically will see their urologist first, or they'll go to their primary care doctor, have their urine checked. They may feel like they're having a UTI, although UTIs are less common in men compared to women. But they might feel like, oh, there's something wrong. I want to go to the urologist. So the urologist is likely to test their urine. If the urologist is doing sometimes they'll prescribe oral antibiotics, and with or without a positive culture. A culture is not the original pee in the cup. It's the dipstick is when they're original checking the urine in the cup. A few days later, you might get a call from your urologist and say, oh, don't take this antibiotic. That's the culture. When the cultures for a lot of my patients, they come back negative. So now the doctor might say, don't take the antibiotics, or there's no point. Many times when patients still have their symptoms, a week later, they go back to the urologist and they say, oh, well, I took the antibiotics, it didn't help. What now? And then they go back to the urologist a second time or a third time, and now they're looking at another urologist and trying to see if maybe they know what it is. Sometimes they'll have urodynamic studies, which evaluate the pelvic floor. Sometimes they'll have a cystoscopy, which is a catheter going into the bladder, or an ultrasound of the bladder. Sometimes they'll do a kidney workup. Usually most of these things have been done before they see me. If they're presenting with rectal symptoms, they're most likely have already gone to a GI doctor, or they're referred by their primary care doctor to a GI doctor. And in this case, they're either looking for polyps or something within the colon. They might have had a colonoscopy. If they have bleeding in their toilet paper or bleeding in their stools, they're being worked up for possible innate malignancy. But also, hemorrhoids, internal hemorrhoids, external hemorrhoids. They may have an anal fissure, which would be like a glorified cut at the anus, which hurts a lot. But oftentimes patients will not necessarily get the right answer that they're looking for, despite having gone to multiple doctors. Now, if they're presenting with erectile dysfunction, many times they'll go to the urologist as well, or they'll speak to their primary care doctor, and they might have some blood work, including hormones evaluation. They might have a penile ultrasound. Sometimes they do injection into the penis area to evaluate for the blood flow, and then do the ultrasound. They could do a trial of oral erectile dysfunction medications to truly see whether this is an erectile dysfunction. But many times, like I said, concomitantly with pain, you can have erectile dysfunction, rectal issues, and urinary issues. So the urologists typically are, ruling out interstitial cystitis, inguinal hernias, abacterial prostatitis, which means a non-bacterial prostatitis issue, which patients tend to be told that they have a prostate issue, or I have prostatitis, but they don't understand what abacterial means, that doesn't mean there's bacterial. So there's no bacteria in this prostate inflammation. Sometimes it's something like a testicular torsion, recurrent UTIs, or erectile dysfunction. Inguinal hernias are in the inguinal canal, which is in the groin on the right or the left. And sometimes patients will have a history of this. When they were younger, they had an inguinal hernia, or if they have a history of heavy lifting, sometimes they have one that they didn't know they had, which could be something like an occult hernia, which is something that I'm often diagnosing in patients. Interstitial cystitis, it's a controversial diagnosis. There are some people who don't believe it exists, and there are people who do believe it exists, but a lot of times with the interstitial cystitis, dietary management can help if it truly is interstitial cystitis, but it's questionable. So diagnostic imaging, what are we doing? There's the MRI of the pelvis to look out for any hernias. There's MRI's hip to rule out any impingements of or labral tears, and MRI pelvis. So these are things that I order for patients because I want to evaluate the musculoskeletal between the belly button to the knees is kind of my fair game. Hernias can cause issues in their groin, which affect the nerves going down to the genitals. And then hips, obviously, are very confusing for people because if you're going to a urologist, many times a urologist doesn't understand that the relationship between the hip and the pelvic floor is so close. Getting evaluated by someone who understands that connection. Even some orthopedic surgeons don't necessarily understand the connection. But if you look at a hip and you see where the hip lies in relationship to the pelvic floor, you can see that it's quite close together. The MRI of the pelvis to evaluate the nerves. This is not as commonly diagnosed throughout the country. I mean, where I am in Manhattan, I'm blessed to have that ability to order MR neurographies where we can evaluate specifically for the pudendal nerve, the ilioinguinal nerve, genitofemoral nerve, a bit more common, but it is a helpful tool. Majority of our patients who do feel like they might have some pudendal nerve involvement sometimes want to have imaging, and many times I tell them that majority of times the reports are negative and it's not necessarily a pudendal entrapment as opposed to a pudendal neuralgia. So neuralgia being pain in the distribution of the pudendal nerve, and an entrapment being an actual entrapment of the nerve. Gastroenterology, so GI doctors. When I see patients who have a history of chronic constipation, a colitis, whether it's Crohn's or ulcerative colitis, any condition that affects the rectum or the bowels can cause pelvic floor dysfunction or pelvic pain. So understanding that, I've actually been talking to the Crohn's Colitis Foundation because not all GI doctors understand the connection between the bowels and the pelvic floor, and anything that can go through the pelvic floor is fair game to have an irritation or an inflammation of the pelvic floor. And if the pelvic floor is irritated, it can then cause other pains, all the other pains that we talked about, perineal pain, penile pain, testicular pain, sexual dysfunction. So similar to diverticulitis or history of hemorrhoid surgeries, proctalgia fugax, which is an anal contraction that's short, and levator ani, which is a long chronic condition, proctitis, inflammation, and then irritable bowel syndromes. Musculoskeletal causes. This one's a little bit confusing. It's a sports hernia. It's not necessarily a true hernia. In this scenario, it is an actual muscular tear close by to the pubic area. And for patients, they're typically seen in patients who are athletic and participate in sports. So that's why it's called a sports hernia. But patients with athletic pubalgia will have pain in their pubic area and have pain, and then can also present with all of the same symptoms. So there is that's why we order that MRI pelvis to actually evaluate for that as well. Coccydynia, which is the tailbone, pain in the distribution of the tailbone. Believe it or not, there's not much that you can do surgically. There's nothing you can do surgically for tailbone pain, but there is plenty that you can do for the pain itself. A lot of people say, oh, my tailbone hurts and I want to just get rid of it. There's, even if I fall on your tailbone, the treatment is basically nothing for your tailbone. But in terms of pain, if the tailbone is now shifted in a way that is now irritating the muscles attached to the tailbone, like all of those muscles that I said, coccygeus to pubococcygeus or iliococcygeus, that means they're connected to that bone. Those muscles can actually be inflamed, irritated, they can get more tight, and that could be why you're still having pain in that distribution. So manipulating or massaging those muscles can actually help relieve some coccydynia. Levator antispasm, that is particularly for the muscles that are connected to the anus. So the three muscles I mentioned, puborectalis, pubococcygeus, and iliococcygeus, those are typically the anus muscles, or the ones that are, well, the puborectalis is more the one that's holding in the rectum. And when those muscles are in spasm, you can feel a spasm at your anus, and that can cause pain for patients. Osteitis pubis, or that's pubic symphysis dysfunction, so right over your pubic bone. And it's more commonly seen, I feel like, in females than males, but definitely can exist. Piriformis syndrome, more of a muscular tightness of the piriformis muscle. The sciatic nerve can travel between it, above it, below it. And so for a lot of patients, they feel like this mimics sciatica or radiculopathy running down their leg, but it's truly not coming from their lumbar spine. It's coming actually from a tightness of a muscle in their glute. And then this can cause pain going down their leg. The SI joint. The SI joint, sacroiliac joint, is between the sacrum and the iliac. So it's the part of the pelvis that's from the back, and it's on each side, and sometimes this can also cause pain. This is another one that affects women more, I feel like, than males. Labral tears. Labral tears are very common in men. Labral tears are essentially the shock absorber. So labrum is the shock absorber of the hips. So there's the pelvis, and then there's the labrum. The femur sits inside of it. And when there is any injury to this area, the labrum can tear minimally, can tear significantly. I've seen this so incidentally in many patients that they tend to worry, but because I see it a lot, I'm not so worried. A lot of it is strengthening the hip muscles to prevent the tear from getting worse. A lot of people hear the word tear and they worry that, oh, what can I do for it? You probably, like anyone watching this, probably has a labral tear. Now, it's not until it is physically affecting you that you need to necessarily do something about it. For many patients, sometimes repairing the labrum is necessary, and that would be done orthopedically with a surgeon. There is impingements that can happen, as well as, and if there is a deformity in the bone, and that can also cause impingements and pain. I think those are the musculoskeletal ones. Rheumatologic, there is always a predisposition to having pelvic pain if you have a history of fibromyalgia. Rheumatoid arthritis will sometimes present with pelvic pain. There is spondylopathies like ankylosing spondylitis, which presents with sacroiliitis, as well as Ehlers-Danlos syndrome. So patients tend to have hypermobile joints, and that's that. So let's see male symptoms. So typically, let's go into the order of the male symptoms. So these are more rectal. So rectal burning, rectal itching. So you don't have to have all of the symptoms in order to have pelvic pain. A patient could come in just with rectal burning, but they might present with rectal itching, or they might present with rectal numbness. They could have a sensation of feeling like there's a golf ball or something in their rectum that they're sitting on. They can have many patients, almost all my patients complain of pain with sitting. Why? Because you're sitting on your pelvic floor. So if something is going on, then their pelvic floor tends to be irritated or aggravated, and now they're sitting on it all day. So especially with the pandemic, we see a lot more patients are having more or less mobile and not exercising as much, especially since we're going into the winter. And so they have more pain with sitting. Weak erection. So this is some more sexual stuff. Weak erections, pain with erection, pain during intercourse, or pain after ejaculation, incomplete or premature ejaculation, are all sexual dysfunction presentations. Testicular pain, perineal pain, these are the more common ones that I'll see when people come in with pain, because I don't think a lot of people realize there's stuff that can be done for sexual dysfunction alone without pain. Patients tend more to come in when they have pain and other stuff than when they just have erectile issues, because they kind of feel like, oh, well, maybe it's just my age, or maybe this is embarrassing, or maybe I don't want to talk about it. So they don't tend to come unless there's like a pain aspect to it. So perineal pain, basically between the two regions of the scrotum and the anus, all of that is called the perineum. The testicular pain, usually when people complain of pain, it's not testicular and penile, it's usually one or the other, but sometimes patients will come in with both. Typically, they describe penile pain at the tip of the penis, or the shaft, or the entire penis. They could have a numbness or decreased sensation in the on the penis. And that, as we go on, we'll kind of explain why, because there is a specific nerve that innervates the dorsum of the penis. Scrotal contraction, this pain exacerbated by bowel movement should probably, oh, these are the bowel ones. So I think these are a little bit out of order, but scrotal contraction, sometimes patients complain that their scrotum is contracted, and they're not, when they take a shower or they're in heat, the contraction is not as bad, but then when they're not, so that's one of their major symptoms. It typically goes with a syndrome called hard flaccid, where they may feel hard, but they're actually flaccid. Sometimes they wake up in the middle of the night with erections, or they're having pain with the erection. Back to the bowels. So pain exacerbated by a bowel movement, incomplete evacuation is very common, constipation, blood on toilet paper, which typically indicates that there is possibly an anal fissure, coccyx pain, which we talked about, buttock pain, which is kind of similar to the piriformis syndrome, pubic symphysis pain, abdominal groin pain, which kind of indicates could it be a hernia. And then urinary frequency, urgency, incomplete voiding, weak stream, very common. SI joint pain, so these are the more musculoskeletal ones now. SI joint, hip pain, hypermobile joints. And this sensation of being hard when not erect, that was supposed to go with the scrotal contraction, so I must have added that later. All right, erectile dysfunction. So erectile dysfunction, when there is a high tone in the pelvic floor muscles, how I talked about the muscles being tight, they can cause erectile dysfunction due to the compression of the lumen on the internal pudendal artery. So there might not be a lot of blood flow. And because, like I said, there is a high prevalence in patients with pain who also have erectile dysfunction. Now let's try to understand what all of this means. So bladder, prostate, the penis, and the scrotum. So the bulbospongiosus muscle, which we talked about, and then the ischiocavernosus muscles, which were on the sides, essentially they're innervated by the pudendal nerve, which I kind of alluded to earlier, but we didn't get there. The ischiocavernosus muscle compresses the roots of the corpora cavernosa, and then when both of these muscles are contracted, it leads to an erection. So a lot of moving parts have to happen in order to have an erection. An ejaculation occurs when you have simultaneous, so ejaculation, there is a contraction of the prostate, there's a contraction of the bladder neck, and then relaxation of the sphincter, right? And then the contraction of the bulbospongiosus muscle of the pelvic floor, which is here. And then you need to have a strong bulbocontraction to allow the semen to come out for the ejaculation. And so, it's a little bit actually more complicated for men than it is for women in terms of the erectile dysfunction, because there's so much that plays a role in the ejaculation and in the erection. So essentially what I was trying to very simply, the pelvic floor is really important in this. And I think you can see how that plays that role. Treatment options, very basically, very simply, that anyone can do at their home. Magnesium, Epsom salt baths. Magnesium is a great muscle relaxer. That's kind of a very natural vitamin. It helps relax muscles. They're usually found in Epsom salts. And, it helps with the bowels, and it helps with, magnesium citrate's great for stool consistency. Pelvic physical therapy. Now, this is a little bit more taboo, especially in Muslims in general, because, what does this mean? Pelvic physical therapy. This actually means that they go in intrarectally and evaluate the pelvic floor. When they go in, they might do some manual work at the rectum, because unfortunately there's only one entrance into the pelvic floor for males. So they have to go in somehow, and that's how the examination to diagnose the pelvic floor dysfunction is done rectally, as well as treatment. There's not just going in and massaging. There's a lot to it. There's TENS units. There's biofeedback that can be done to teach you how to relax those muscles. They can teach you breathing exercises to relax those muscles. They are focusing on They could do anal manometry, which is essentially putting a balloon in the rectum to try to stretch out the rectum and allow a feedback mechanism so you understand when to have a bowel movement. It can help with diarrhea and constipation. So it's not just manual manipulation in the rectum. There's a ton of stuff that they're doing in that amount of time, as well as working externally. So they're working on the perineum. They're working on the adductors, which are the muscles that attach from your inner pelvic groin to your knee, like those inner thigh muscles. They're working on your glutes, their piriformis, because if these muscles are all tight, it's a natural tendency for your pelvic floor muscles to be tight. And we didn't really get into any of the psychological stuff, and I feel like I'm almost at the treatment, but I should have done a whole psychological slide. But when you have anxiety or any depression or stress, people tend to clench their pelvic floors. So if their pelvic pain is getting worse when there's more stress, that's a very big indicator that their pelvic floor is definitely clenching. If it's clenching, it's causing more pain, because when muscles are tight, they're squeezing nerves, and nerves are what cause pain in bodies. So just understanding that how to breathe to stop yourself from clenching helps. And a lot of people teach diaphragmatic breathing, which is another way to call it belly breathing, breathing in through your mouth, and while you're doing that, pushing your belly out, and then breathing out through your mouth and bringing your belly in. That actually drops the pelvic floor, as opposed to bringing it up and clenching, which a lot of people, I feel like people don't know how to really breathe well. And so now we'll go back to medical stuff. So rectal, so that's what the physical therapist does. And I often get confused for a physical therapist because I'm a physiatrist, but I did go to medical school. I work with my physical therapy colleagues on a regular basis, mostly because they are doing a lot of the manual work, and I'm doing more of the interventions, which include diagnosis, imaging, prescriptions, and procedures. Here where we are, the physical therapists are not allowed to needle, obviously not allowed to do any injections or order suppositories or medications. And so our roles are different, but we work together as a team. All right, so what can we do? There are suppositories that can be used to relax the pelvic floor, typically diazepam compounded with baclofen for muscle relaxation, and this they're both used to relax the pelvic floor. This is not meant to be on a daily use forever and ever and ever, but sometimes to kickstart a patient's treatment program, we'll use suppositories. We can use a whole sort of compounds, which is great because if you have a good compounding pharmacy, they'll make anything. Many patients who defer taking oral medication were able to use medications into the suppositories, and that localizes the effect of where we want the medication to go. Obviously, there is a little bit of systemic absorption, but not as much as taking it orally, so patients don't typically feel the side effects of taking something by mouth when they're taking it rectally versus mouth. Creams, similar to the suppositories. Creams, if you have a good compounding pharmacy, you can find you can make almost anything, and I'll do combinations of ketamine or amantadine with amitriptyline or gabapentin, lidocaine, but it really depends on what their symptoms are, if they're feeling a nerve issue, or if they're feeling a spasm, or if they have an inflammation, maybe I'd add a ketoprofen. It really just depends on what we're focusing on and where we're focusing on. So sometimes I'll give them something for their nerves and a cream for their nerves, and sometimes I'll give them a nerve for that, and then also for pain relief. Because a lot of times when they're having pain, they want to deal with the root of the problem, but they also just want to get out of pain. And so depends on the combination of what their issues are and what their symptoms are. Oral medications, I typically prescribe SNRIs or membrane stabilizers like gabapentin or Lyrica. I'm not a huge fan of the tricyclics, although I know a lot of my urologist colleagues are. I tend to find that tricyclics give patients a lot of side effects. Now, it also depends on the person. It's hard to say what side effects anyone will get until they've started to try something. But nerve medications work on the nerve issue. So that neurogenic inflammation, they might also have concomitant anxiety or depression. And so depending on the patient, if they also do have anxiety, then maybe something like an SNRI, like the antidepressants, would be more helpful for the patient. And I try to explain to patients that although they are labeled as antidepressants, they may not necessarily be for them. Many times that they are at much lower doses. So a psychiatrist might not find it as effective for their mood, but might be enough for their pain. And also mast cell inhibitor like hydroxyzine, as I used to prevent the release of histamine in the bladder, and mostly for patients with urinary symptoms. I'll use that. Therapy should be, tailored to each individual person. They're focusing on the neuromuscular reeducation. They're using things like ultrasound and TENS. So ultrasound is a device to evaluate the muscles, and TENS is like an electric stimulation. It's using deep heat that can help patients with their pain. And if you go to physical therapy for anything else in the body, it's similar to that, except they're also doing some internal work as well. Biofeedback to reduce the baseline tone. So this is when, if you see that, oh, well, at baseline, I'm at, my tone is this, and then by putting electrode near your rectum, they might be able, you can see, oh, well, this is how your muscles are contracted right now. Let's try to reverse that and undo that. And by teaching you how to relax, now you know how to relax when you're not attached to a biofeedback machine. So it is supposed to teach you. And these can often be rented or prescribed by your doctor to purchase for yourself. Soft tissue mobilization, myofascial release, and connective tissue manipulation, which is basically the stuff that we were talking about that are done internally and externally. More treatment options: acupuncture, craniosacral. So acupuncture, it depends on the person. Not every acupuncturist feels comfortable doing things in the pelvic area, but if you find someone that you trust, there are acupuncturists who feel comfortable doing perineal needling in the bulbospongiosis or the ischiocavernosus, but it is quite rare to find, even here where I am in Manhattan. Craniosacral, so I'm, as an osteopath, we believe the body is a full unit, and between the cranium and the sacrum, your entire spine is connected. And so some osteopathic manipulation techniques including craniosacral, can help neutralize the spine. Yoga, so is one of my favorite exercises for patients. It's low impact and more specifically restorative yoga. So nothing that is difficult or hard to do. You really want to just get the blood flowing. You don't want to try to make yourself hurt in some way or do a stretch that is too challenging. It's more about improving the blood flow, especially for people who when they're having pain, they tend to be less active and not moving as much as they should. And because of that, if you pray, when you pray and you do your sajda and you're going down, you see that you're actually getting a lot of movement in your pelvis. And so I think there's definitely some benefit to doing, what are you doing? You're getting into child's pose. I mean, you're not lying on your back and doing happy baby, but you are, doing different positions, forward bends, things like that. So you are getting some movement throughout the day, but, dedicating maybe 20 minutes or 30 minutes to yoga can actually improve your blood flow. Meditation, prayer. I often tell patients whether they like to pray or color or sing or do something that reminds their brain when they're not in pain, and that can help retrain the brain from a time when you didn't have pain, and to do that a couple times a week to kind of reset. Therapy. If there is underlying issues that need to be dealt with, whether it's sexual trauma or unwanted sexual abuse, or forget even sexual trauma, even just emotional abuse, whether it's a sibling tormenting you through your childhood about bowel movements, or being yelled at to urinate, 5 times a day or before you leave, or, that can be considered a trauma as well. And so OCD clinics, cognitive behavioral therapists, sex therapists are available as well to help deal with these issues. And if you don't really treat the underlying issue, there can always be continued problems. Something that you can do at home. Now, I don't typically recommend this for someone unless they've actually had some sort of guidance. A pelvic wand. This is a male pelvic wand that actually a patient or physical therapist, Summer Sahuri, she's down in Florida. She's a physical therapist, a Muslim therapist down in Florida, and she had a patient who created this in his garage. And this is not the best picture, but you can see that it's actually it probably goes up to here. It's a little bit of a hook. It actually has more length to get further, whereas female wands are a little bit different. They look a little bit more S-shaped. My male patients have found that this wand is more helpful. Like I said in the beginning, please use this under the direction of a physical therapist and not at home. And I don't even want to go into more detail about it because I really don't want you. I want to make sure you understand that you can hurt yourself if you're doing this improperly. You really have to be as gentle as you would be to a tomato, so you're not bruising the tomato. And less is more, so you don't want to be in there for longer than you need to be. Also, use lubricant. So what else can we do besides the medications and the acupuncture and the physical therapy? There are nerve blocks that can be done, and I do these in my office. So this is done by a physician. Typically, I'll do trigger points and nerve blocks, and I'll focus on different nerves, including the pudendal nerve and the posterior femoral cutaneous nerve. So these are not the best pictures because I hope I added another picture, but this is looking at it from the back, so it's a little bit hard to see how this relates to the genitals. This is a little bit better. So you can see that there is the pudendal nerve. It has a big branch coming through here, and then this is one side. This is your sacrum. That's your coccyx. And so the pudendal nerve has different little branches. One goes to the perineum, one goes to the dorsum of the penis, that's the dorsal nerve of the penis, and then to the rectum. I don't think they put the rectal branch on here. And then their inferior cluneal nerve, that is, it's the posterior femoral cutaneous. I don't think it's on here either, no. But those are the major nerves. And then we talked really quickly, I think earlier, about the genitofemoral nerve and the ilioinguinal nerve, and that's the one that goes through the ilioinguinal canal, and the genitofemoral nerve, which it goes to the genitals and the femur, genitofemoral, so genitals and femur. So those are the four major nerves of the pelvis, and just so you're not confused because there's so many nerves on here, sacral nerve roots are much higher, and they're all like little branches coming off. So the major one is the pudendal. When we do nerve blocks, I don't know why this looks like a baby, but it's not. It's supposed to be, I think. The ilioinguinal and iliohypogastric nerves are running across like here, and there's the transverse abdominis muscle, and we'll take a needle and we'll go in and block right there. And then the piriformis muscle, there's the ischium, and we will do a pudendal nerve like that, nerve block. I use ultrasound guidance to see where I'm going based on musculoskeletal landmarks. And that's it.
Thank you so much, Dr. Ahmed. That was very interesting. And, from, going to medical school myself, there's such a greater emphasis on, understanding the female pelvic muscles, understandably, of course, but even from a non-medical standpoint, just for females in general to be aware of their pelvic floor and their pelvic muscles. I don't know, I notice a big contrast. I'm sure you feel the same, that most males are not well educated about their pelvis. And from a preventive medicine standpoint, for those, family physicians out there, internal medicines out there, for a clinical standpoint, an outpatient clinic, what advice can you offer to kind of allow this education for our male patients, or to encourage, our family doctors to kind of encourage their male patients to have an understanding? And also, I had another question, was the age range for the cause or for male pelvic pain. Is this something that you would see in young men as well?
I see patients as young as 16. Obviously, they come in with their parents. It's just so it's consented, but for any procedures or exam or anything. But I've seen as young as 16. Some of them are mostly some sort of trauma, whether their friend kicked them in their genitals, or they've had rough intercourse or something. I think the important thing is I've been so far removed from family practice, so I don't know if they're asking them about issues with their genitals, or if they're asking them about their bowels, or if they're asking them about urinary symptoms, or if they are they just straight up sending them to a urologist or a GI doctor. Most of the time, my patients are very much frustrated because it takes them years before they find someone like me who understands that their pelvic floor exists, because even though a GI doctor or a urologist knows it exists, isn't always thinking about it. And many times they go through 3 or 4 urologists before a urologist will say, oh, well, you've been on about 20 antibiotics. Maybe this is pelvic floor dysfunction, because, just like the GYNs are not necessarily taught to evaluate the pelvic floor. So it's quite possible that the urologist was not, educated on the pelvic floor, like we weren't educated about it in medical school. I guess if a patient is continuously complaining about a symptom that is not getting addressed by their doctor, whether it's a specialist or not, maybe referring them directly to pelvic therapy, and then they can try to get some guidance from their therapist, because most physical therapists are more aware of this than, sadly, some doctors.
Yeah, I would agree. Thank you for that. We do have a question about the amount of sex, or the amount of sexual activity, and is there a connection between, in particular, the lack of sex and having stress in the pelvic area?
So typically, understanding what an orgasm is when you're having a bunch of little tiny contractions, is when you will have an ejaculation or an orgasm. So when a muscle is already tight, now imagine having a bunch of little tiny contractions. That typically doesn't feel good. If a muscle is more relaxed and then you have a bunch of little tiny contractions, you're typically going to you're not going to necessarily have pain. Does that make a little sense? So if a person has a baseline tight pelvic floor already, and now they're having intercourse or masturbating or, repetitively, and it hurts, then most of the time they tend to avoid it, because they know it's going to hurt, or sometimes they try and they're sadly disappointed that, oh, it did hurt again, but they want to maintain intimacy in their relationship, so they're continuing to have intercourse despite the pain. Now, the pain, like I said, it could be pain after intercourse and not necessarily during. They could have great intercourse, but then the pain is after, and that's because of the little the little, I think it's like 20 contractions in like 0.8 seconds or something like a lot. In terms of not having intercourse, could that cause pelvic pain? Is that what the question was?
Yeah, I was asking about that. It seems like it's the opposite, that it's the lack of sex isn't leading to stress. It's rather that the stress of it is.
No, I mean, if someone's saying that they're not having sex and that's stressing them out, and then are they clenching because of that? Could that cause pain? I mean, that could, because anything that causes you to clench. So a lot of people will have, a lot of people tend to hold their stress in different places. So some people hold them in their jaw, and they present with like night grinding their teeth, and they need a mouth guard when they sleep, or they find their spouses are telling them, oh, you're grinding your teeth all night long, I can hear it. Or they get headaches a lot, and that's, typically they're clenching their neck muscles, and now they're, more tense there. But then a lot of people are clenching their pelvic floor. So if stress is causing you to clench your pelvic floor, that can cause pain, but usually not now, if he's talking about the backflow of the hydraulics of the whole system, could that potentially, it could, if it's not released, if semen's not necessarily released.
Okay, that makes sense. And when you were talking about a little bit more about that, the stress of the pelvic floor muscle, for in the talk that you had back last year for females, which Kutsia actually, that is posted below in the comments if anyone is interested in looking at that. We talked a little bit about vaginismus in females. Is there something similar like that with males? When you talk about the tense pelvic floor, is that something in which, in regards to stress or, psychological, that people can naturally kind of tense up their pelvic floor muscles in the same way that females can?
I mean, it's not necessarily called something like that. It's actually more of like a vague pelvic floor dysfunction, or, it ends up being called like a acute or a chronic bacterial abacterial prostatitis. The interesting ones in the males are hard flaccid. And that's not common like vaginismus. I see vaginismus like every single day, but you don't see like a hard flaccid every single day, because these are like relatively new terms that are coming out. Some stuff that men do that tend to cause pelvic pain later in life, reverse ejaculation, where they don't ejaculate and that's actually, they're keeping it in, or like they're doing like Kegels because they're reading stuff from magazines, and that tends to cause issues because of the same way if you're doing like 300 Kegels a day. I think a lot of men's health magazines don't realize that the danger they're putting in people. Now, I mean, this doesn't necessarily affect everyone, but it is the perfect storm. If you have a type A personality type who's sitting all day, who's very anxious, and they're doing these things, you can present with pelvic pain. We always say pelvic pain is more of a perfect storm than anything, because it's not just one thing. And then you have a fall on your tailbone, or you fell off, or you're in a history of biking or spinning. And then, you're putting a lot of pressure on your pelvic floor, or you're weightlifting. It really just depends on what's going on in the person. So no specific diagnosis similar to vaginismus, but if you had to, it would be more like erectile dysfunction.
And then we have one more last question, and this is regards to depression as a result of chronic male pelvic pain. Is what advice can you offer for a wife whose husband is dealing with this, and obviously it's impacting their marriage and their intimacy? What is something that you have experienced in office or with your patients, and in terms of how to deal with the the mental the well-being of the patient in regards to the pain?
So not in regards to the wife, but in regards to for advice for the wife or for the patient?
The wife is asking technically on behalf of the husband who is dealing with.
Oh, okay.
Yeah.
So, I mean, in regards to the wife, I'm sure if this were a scenario where it was my husband, I would want him to get help. And, I would want him to seek help despite the taboo and the stigma that comes along with it. Part of the reason why I'm so active on social media was originally so I could get more Muslim people to seek help, because I was seeing so many Caucasian patients and African or Black patients, but not necessarily, patients like us, minority groups who can reach out because of the taboo of this topic. So, if the patient is feeling depressed because of this, it's very common. That depression cycle, pain, depression, anxiety, pain, depression, anxiety, it's hard to get out of that unless you treat each of those, the pain, the depression, and the anxiety that is associated with it. So like I had mentioned before, cognitive behavioral therapy, or a sex therapist, or someone that you can trust and talk to, a pelvic physical therapist. Getting the validation that your symptoms can get better, can go away. Because many times, like I said, if you go to like 3 or 4 urologists, the patient tends to get a little frustrated, upset that they're not making any improvements. And if they are never told what is actually wrong with them, or they're told, I find a lot of my male patients tend to feel like it has to be something wrong. There's something wrong. You have to find something wrong. And because you can't see the pelvic floor, they get a little disappointed that there's nothing to physically see. There's no rash. There's no blood flow issue that you can't see. There's no mark on the genitals. And it's hard for them to understand that there could be just the pelvic floor that you can't see as causing problems. Mm-hmm. And then as a patient is getting treated, symptoms get better. Not all of them at the same time. Usually the bowels will improve, the urinary symptoms may improve, and then the pain is usually the last to go. And I've seen patients significantly improve just with, a couple of things, or they want the whole kitchen sink. They want me to throw everything at them. I mean, men tend to want everything and not just like one or two items conservatively. But,
Mhm.
I would say just really, really encourage them to seek help and try to find the right provider, because many patients will come in and they'll say, my wife made this appointment for me, or my mother made this appointment for me. And they don't, they're kind of just annoyed, and they're like, okay, they kind of give me that look like, am I in the right place? Is this really even something like, and because they feel like I'm going to just take their urine and I might diagnose them with a UTI or prostatitis or do something. And then when I tell them, no, there's this thing, it's called the pelvic floor. And then they're just like so happy and to know that there is something that could be causing it. And then, having constant communication with the patient to see how they're doing after they started therapy. And I reach out to the therapist and say, how is this patient doing? Is there things better? Is he less tight? Or we start maybe some suppositories. Then the patients start to feel like, okay, I can see a light at the end of the tunnel.
Wow, that's amazing. It's really nice to hear that, and thank you so much for sharing your expertise and for that advice in particular, especially for those who are listening who may be dealing with this on a personal level. That was very inspirational to hear. There are other people who are going through this, and the positive outcome that can come as a result of taking a proactive stance on your health. I want to thank you so much, Dr. Ahmed, for joining us again. We would love to have you back in the future. You're very well liked within our webinars, and your topics are very interesting to the community as well. So we would love to have you back. The session is being recorded. We will also share Dr. Ahmed's social media handles, or if you're interested in seeing what she is up to or any other information that she'd be willing to share with her permission. And with that, we will close for tonight. Thank you again, Dr. Ahmed, and we look forward to having you back. Assalamu alaikum wa rahmatullahi wa barakatuh.
Walaikum assalam. Thank you so much.